Hello, my name is Dr. Henry, and this is a video on general physical examination. So in this video, we will try to explain everything you will need to know about general physical examination. This video will be divided into 3 parts. In the first part, we will try to briefly explain some of the theories you need to know before performing a general physical examination. Then in the second part, we will perform a detailed step-by-step general physical examination. Then in the third part, we will try to limit it to an OSCE scenario, which is 3 minutes. So we'll try to perform general physical examination within 3 minutes, as it will be in an OSCE scenario. So part 1 of the video, theories of general physical examination. So a general physical examination is the first step of a full patient exam, and it provides an overall impression of the patient's health. In every physical exam you ever perform, just bear it in mind that there will be 3 parts to the exam. So we have the pre-examination, the examination, and the post-physical examination. So in the pre-exam, this is where you have to greet your patient, you introduce yourself, you take permission from the patient for the examination you're about to perform, then you perform your hand hygiene, then you properly expose and position your patient. So these are the things you need to do before you perform any exam at all, be it general physical examination or any systemic examination. So this is constant. You introduce yourself, you greet the patient first, you introduce yourself, you take permission from the patient, then you perform your hand hygiene, then you properly expose and position your patient. So this is constant for every exam. Then at the end of every exam, which is the post-exam, you have to greet your patients and probably explain, depending on the exam, you might have to give them a little bit details of what you found out during your physical examination. So the pre-exam and the post-exam is constant for any type of exam. So now in the physical examination proper, normally in physical examination, we have 4 techniques we use. We have the inspection, we have the palpation, we have percussion, and we have auscultation. We call it IPPA. That's the technique we use for every physical examination. But in general physical examination, we'll only make use of inspection and palpation. There is no percussion, there is no auscultation. So I like to think of general physical examination in 2 phases. The first phase is a non-touch general survey, where you would observe your patients and maybe any device attached to them. Then in the second phase, you will have to touch them and observe them in detail from head to toe. So I like to think of it in those 2 phases. So in the first phase, which is the general survey where you don't need to touch the patient, there are 4 things you should be looking out for. The first is the state of health of the patient. The second is the posture. The third is any other striking feature you can observe. Then the fourth are attachments, maybe medical attachments around the patient. Don't worry, I will take out time to briefly explain each of these points. Then you'll now do a detailed observation from head to toe, where you will check out for features of systemic inflammation, which includes pallor, cyanosis, jaundice, finger clubbing, the febrile state, lymphadenopathy, edema, and hydration. So these are features of systemic inflammation which you will try to observe when you'll be touching your patient from head to toe. I will briefly explain each of these before we go into the examination proper. State of health. So the first thing you observe in your patient is the patient's state of health. That is your patient healthy or is your patient ill? Those are the 2 things you observe first. Now, if your patient is healthy, you just say a healthy looking patient. But if your patient is ill, you need to classify the illness into acute or chronic. And you need to give us the evidence of why, or give us the reason why you think the patient is ill. So your patient can either be healthy or ill. And if your patient is ill, give us the reason why you think your patient is ill, which is the evidence of the illness, and you still tell us if it's acute or chronic. So that is to say, if your patient is ill, it can either be acute or chronic. Now, an acutely ill patient is generally evidenced by distress. So the distress can be painful distress or respiratory distress. So painful distress can be in form of vocalization of pain or protection of the painful parts by the patient. Some of the signs of respiratory distress include fast breathing, nasal flaring, chest retraction, and a lot of other things can be used as signs for respiratory distress. So when you say a patient is acutely ill, probably maybe the patient is in painful distress or the patient is in respiratory distress. Now, when you say your patient is chronically ill, so that means that there is a long-standing illness, maybe that have lasted more than 3 months. And some of the things you will use to identify if a patient is chronically ill are things like presence of bony prominences, okay, and then maybe muscle wasting, skin folds. So these are things that will tell you that this patient is chronically ill. So like I said, we have acutely ill patients, which is evidenced by most times by painful or respiratory distress. Then we have chronically ill patients, which are evidenced by maybe muscle wasting, bony prominences, and then skin folds. So these are the 2 things that will tell you if a patient is acutely ill or chronically ill. Then again, in some cases, we might have what we call acute on chronic. That is to say, a patient who has been chronically ill but have signs of maybe painful or respiratory distress. Okay. So you can say that is acute on chronic. So that might be as a result of exacerbation of the chronic condition, leading to acute exacerbation of the chronic condition. So you can say this patient is acute or chronic. So, like I said, in state of health, you are trying to determine if your patient is healthy or ill-looking, because someone can look healthy and still be sick. So we are just trying to determine by looking, does this patient look healthy or does this patient look ill? And if the patient looks ill, you tell us if it's acute or chronic, then tell us the evidence why you think the patient is, that made you think the patient is ill. So that's just for state of health. So the second thing you have to observe about your patient is the posture. Is your patient lying down comfortably, sitting, standing? Just the posture of your patient. Or is your patient relaxed? Okay, so these are the things you have to observe about your patient. In some conditions, your patient might have abnormal postures like decorticate or decerebrate postures in neurological injuries. So most times in your OSCE scenarios, you get a normal patient, but you have to be aware of the fact that you might have a patient with neurological deficits. So in that case, you have to be aware of what we call decorticate posturing, where the arms will be flexed on the chest and the fists clenched and the legs extended. So this suggests a neurological injury. Then we have the decerebrate, which is actually more severe, where the head is arched to the back and the arms and legs are extended and internally rotated. This actually has a worse prognosis than decorticate posturing. So just be aware of this, but most times your patient will be normal. So you have to mention the posture. Probably your patient, I can see a patient lying, sitting comfortably or lying comfortably. So that is that for posture. After the state of health and the posture, then you try to look at your patient from head to toe. Try to know if there's any other thing you can observe, any other abnormal thing you can observe, and mention it. In pediatric cases, you might be able to notice what we call a moon fascie, which suggests Cushing syndrome, or you might notice what we call the wizened old man appearance in the case of severe malnutrition. So these are some of the things you can pick out by just looking at the patient. So try to look at the patient from head to toe, wizened old man appearance for severe malnutrition. You can also look for dysmorphic features, probably something like in Down syndrome. So there might be dysmorphic features on the face. So you notice that. Then you look at the hair, the texture of the hair. So the texture and the distribution of the hair can actually help us notice the nutritional status of the patient. Then again, you look at the skin. Notice any obvious skin incisions, any rashes, any scars. Then look at the limb. Probably notice any limb length discrepancies there might be. Just generally take a step back, look at your patient from head to toe, and try to mention any abnormal finding you can find out. So that's it for the next one. Then look at the abdomen, look at the limb, look at the joints without touching the patient. So try to observe. Then mention any abnormality you can find. Then look at the digits. Maybe there might be fewer digits than normal. So try to mention any abnormal findings. But if there's no abnormal finding, no need to mention. Okay. Then after that, you try to take a look at the attachments around the patient. Note any medical device on the patient, such as IV cannula, oxygen masks, catheters, monitors. So that will immediately inform you about the ongoing treatment of the patient. Okay, so try to mention any attachments you can see around the patient. By the time you're done with this, you can now go to the next phase, which is trying to observe your patient from head to toe for the features of systemic involvement. Now, in the next step, we'll carefully observe the patient from head to toe, looking out for what we call features of systemic involvement. So these are outward clinical signs that point towards a disease process affecting the body as a whole, not limited to a particular system. So, and they include the things we listed before. So I'll go into each of them in brief details before we go into the detailed examination now. Now, the first one we'll talk about is pallor. Pallor is the paleness of the skin and the mucous membrane due to reduced blood flow or reduced red blood cell count. So it can be assessed in areas where the blood vessel is close to the surface, places such as the conjunctiva, the oral mucosa, the palm and the sole, palmar creases, and the nail beds. So these are the areas where you can assess pallor. So what are the things that can cause reduced blood flow? Well, someone that has excessive bleeding, okay, or in a case where there is shock, arterial occlusion. So these are things that can cause reduced blood flow. And again, we say a decrease in the red blood cell can also cause it. That's anemia. So in people that have kidney problems, there can be reduced erythropoietin, which will lead to reduced number of red blood cells, so leading to pallor. So these are some of the causes of pallor. So like we said, now we can grade pallor clinically into mild, moderate, and severe. So mild pallor is when it's only evident in the conjunctiva or probably the inner lip. So when the pallor is only evident in the conjunctiva or just the inner lip, we'll say it is mild. Then when the pallor is present in the palm, maybe the palmar crease on the nail beds, including the conjunctiva, so we'll say it is moderate. Then it is severe when it is obvious in the skin and the face and the whole body. So when during the examination, if you notice that if there is pallor, try to grade it clinically into mild, moderate, or severe. The next feature of systemic involvement is cyanosis. Now, cyanosis is bluish discoloration of the skin and the mucous membrane due to decreased amount of oxygen bound to hemoglobin in the red blood cells in the bloodstream. Now remember, in Pallor, we say that there is reduced blood flow or reduced number of red blood cells. But in cyanosis, there is no reduced blood flow. There's no reduced number of red blood cells. What is reduced is the amount of oxygen in the blood. So cyanosis is basically the amount of oxygen reduced, which will give bluish discoloration of the skin and the mucous membrane. So we have two types of cyanosis. We have the peripheral cyanosis and the central cyanosis. The peripheral cyanosis is also known as acrocyanosis, refers to when the cyanosis are found in the extremities, like the palms and the hands and the sole of the feet. Okay. Then the central cyanosis refers when the cyanosis is present in the central parts of the body, such as the lips, the tongue, the buccal mucosa. So what are the things that can cause cyanosis? Anything that prevents oxygenation at the lungs will definitely cause cyanosis, such as asthma, bronchitis, pneumonia, okay, hypoventilation. Then anything that prevents the heart from pumping oxygenated blood to the system would also cause cyanosis, like in heart failure, valvular heart disease, and so many other heart diseases. Then anything that prevents blood flowing very well, can also cause cyanosis, such as polycythemia, which is increased red blood cell mass, which will make the blood flow to be very sluggish. So the three major normally involved in cyanosis are the lungs, the heart, and the blood. So these are the places oxygen passes through to get to the body. So during your examination, if you notice any cyanosis, you have to specify if it is peripheral or central cyanosis. Then one thing to note, a very important thing to note, is that in babies, peripheral cyanosis is most times normal, as long as there's no central cyanosis. Now, jaundice. Jaundice is another feature of systemic inflammation. This is when there is yellowish discoloration of the sclera and the skin due to elevated bilirubin in the blood. So the sclera is the white part of the eye, and it's typically the first place where you notice jaundice. Some of the causes of jaundice can be grouped into prehepatic, hepatic, and posthepatic causes. So some of the prehepatic causes are excessive red blood cell breakdown, such as in severe malaria and hemolytic anemia. Then we have the hepatic causes, such as hepatitis and cirrhosis. Then we have the posthepatic causes, such as gallstones and biliary atresia. Now, on general exam, just note if a patient is icteric or anicteric. So if there's no jaundice, you say the patient is anicteric. But if there's jaundice, you say the patient is icteric or icteric sclera. So that's the most important thing. So finger clubbing is the uniform swelling of the soft tissue under the nail bed and subsequent loss of the normal angle between the nail and the nail bed. So normally, between the nail and the cortical, there's an angle of around 160 degrees. We call it Lovibond angle. Now, in clubbing, this angle straightens out or sometimes eventually exceeds 180 degrees and the nail bed becomes spongy. Okay, so that's what we call finger clubbing. So clubbing often indicates chronic diseases of the lungs, the heart, and the gastrointestinal tract. Now, clinically, clubbing can be staged into five different stages. So the first stage of finger clubbing, there is increased sponginess of the nail bed, but there will be no visible changes of the nails. Now, in the second stage, this is where you lose the Lovibond angle. And this is where we will use what we call Schamroth's window to detect. So Schamroth's window is obliterated by the second stage. Then the third stage, there will be increased convexity of the nail fold, and the clubbing becomes apparent at a glance. Then by the fourth stage, there will be thickening of the whole distal part of the nail, so giving the nail what we call drumstick appearance. By the fifth stage, what we call hypertrophic osteoarthropathy. So there will be striation of the nail and the skin around the nail. During your physical examination, if it is absent, you just say no digital clubbing. But if it is present, you try to stage it clinically with what we just listed. The next feature of systemic inflammation is febrile state. So febrile state is having or showing symptoms of fever. So a patient can be febrile or afebrile. So if there's no fever, you say the patient is afebrile. If there is fever, you say the patient is febrile. If you're able to determine the temperature, you also mention the temperature. But if you're not able to determine it in an OSCE situation, just say the patient is febrile. The next feature of systemic inflammation is lymphadenopathy. So we all know that lymph nodes are normally not palpable, and they're very small, like less than 1 cm. So lymphadenopathy refers to the swelling of the lymph nodes where they become palpable. So the swollen lymph nodes are just your body's natural reaction to infection or illness. So some of the areas where we assess for lymphadenopathy are the cervical area. So the cervical lymph nodes, the axillary lymph nodes, the inguinal lymph nodes, and then the popliteal lymph nodes. So these are some of the areas where we assess. When palpating for the lymph nodes, you have to take note of the size, then take note of if there is pain or tenderness when touched, then take note of the consistency, whether it is hard or rubbery. Again, take note of mating, that is whether they feel joined together and they move together. Okay, then take note of the location, then also take note of the mobility. So for the consistency, if the node is very hard, it suggests malignancy. Rubbery nodes suggest lymphoma. Then soft tender nodes suggest infection. Then mating, when the nodes are joined together and they move together, it often indicates cases like tuberculosis or metastatic cancer. So then there are three important terms you need to understand when talking about lymphadenopathy. We have significant lymphadenopathy, we have localized lymphadenopathy, then we have generalized lymphadenopathy. When we say lymphadenopathy is significant, or when we say we have significant lymphadenopathy, it means the following points have been observed. One, if the cervical or the axillary nodes are greater than 1 cm, then we'll say it is significant. If the inguinal nodes are greater than 1.5 cm, then we'll consider it significant. Okay? So the cervical and axillary greater than 1 cm, then the inguinal nodes greater than 1.5 cm, we'll say it is significant. Then for the supraclavicular node, anytime it is palpable, then we'll take it that it is significant. Another important thing to note about supraclavicular nodes is that if the left supraclavicular node is enlarged, it's a classical sign of abdominal malignancy. So like we said, so if the supraclavicular node is palpable at all, it doesn't matter the size, it is considered abnormal and significant. Then any other sign of inflammation noted, something like discharge, tenderness, redness, also means that it is significant. So that's what we mean by significant lymphadenopathy. Now, when this significant lymphadenopathy occurs in just one area, we'll say it is localized. Then we'll say it is generalized lymphadenopathy if these enlarged nodes or significant nodes are in two or more non-contiguous areas. For instance, if you have the cervical and the inguinal, there are two non-contiguous areas. So if there is significant lymphadenopathy in the cervical and in the inguinal region, then we'll say it is generalized lymphadenopathy. The next feature of systemic inflammation is edema. So edema is swelling due to fluid accumulation in tissues. In general exam, we look specifically for pedal edema, which is swelling of the feet or the ankles, and sacral edema in bedridden patients. To check for edema, you place your thumb firmly over a bony area like the shin or the top of the foot for a few seconds, then release. So pitting is present if the indentation remains where you pressed. Then clinical grading of edema, often used in teaching settings, is by anatomical extent. So grade 1 edema is when the swelling is up to the ankle. Then you say it is grade 1 edema. Then grade 2 is when it is up to the mid-shin. Okay, that's grade 2. Then grade 3 is when the edema is up to the knee. Then grade 4 is when it extends above the knee into the thigh and even the sacral area. So this is the clinical grade we use in edema. So some of the causes of bilateral pitting edema are heart failure, chronic kidney disease, or liver failure, severe malnutrition. Then unilateral leg edema could be as a result of thrombosis or cellulitis. Okay? So if there is pitting edema, you note it. If there is no pitting edema, you note it. So another feature of systemic involvement is hydration status. So this is where we assess if the patient is well hydrated or not. Now, one of the areas where we can check for hydration status is the oral mucosa. So you check the oral mucosa to see if it is dry or not. So if the patient is well hydrated, then the oral mucosa will not be dry. Then another thing we can use to check for hydration status is skin Turgor, where you try to pinch the skin over the clavicle or at the back of the hand. Okay, if it recoils immediately, that means the hydration status is normal. But if the recoil is very slow, that means the hydration status is not normal. Okay, then the final one in pediatrics or in babies, you can use tears, presence of tears, to note if the child is well hydrated or not. So if the tears are present, that means the child is well hydrated. But if the absence of tears, then the child is not well hydrated. Hello and welcome. In the previous part, we explained some of the basic theories you need to know before going into general physical examination. Now in this video, we are going to demonstrate it for you. So like we said, the first thing you have to do, the pre-exam, is to greet your patient, introduce yourself, then take permission, then you perform your hand hygiene, then you expose and position your patient. So we're going to do the pre-exam now. Hello, good morning.
Good morning.
My name is Dr. Henry, and I am here to perform a general physical examination on you, which will involve me touching some parts of your body. Can I go ahead?
You can.
Right. Remove your shirts, then lie down. Then keep your hand like this. Then you perform your hand hygiene. Now, we are done with the first part, which is pre-exam. And so you make sure you expose your patient very well. Raise the leg of your trouser above your knee. Now, our patient is properly exposed for this examination. Now, like we said, the first part of the examination is observing your patient, okay, without touching the patient. So looking at the patient from head to toe, observing the state of health, the posture, any other striking feature, and any other attachment around. So that's what we're going to do now. So when you're done observing the patient, you note the state of health of the patient. Then I'll go ahead to perform other observations I talked about. So you start your examination from the hair to the toe. So that you'll be very systematic from hair to toe. So you start from the hair, you touch the hair to feel the fluffiness of the hair and the sparseness and the texture and the sparseness of the hair. Some chronic illnesses can cause the hair to be very sparse. So then you check if the patient is febrile, okay, by touching the forehead. Then you lift the upper eyelid. So lift the upper eyelid, then tell the patient to follow your finger. Please, can you follow my finger down? So you're trying to look at the sclera, the white part of the eye, to check if there's jaundice. Then you use your thumb to depress the lower eyelid to check the conjunctiva for pallor. So there's no pallor. So to check for pallor, then you get to the mouth. Now, before you tell the patient to open the mouth, you look around the lips to see if there's any cyanosis noticeable around. If there's none, then you give the patient 3 instructions when you get to the oral cavity. Tell the patient, open your mouth, bring out your tongue, raise up your tongue. You must give that 3 instructions, even if the patient is normal. This exam is showmanship, especially in OSCE situations. Make sure you do everything, even if the patient is normal. So, Mister, can you open your mouth, bring out your tongue, raise it up? Good. So you're checking for 4 things. You check for central cyanosis, you check for pallor, you check the oral hygiene, then you also check for hydration status in the oral cavity. When you're done with the oral mucosa, you check the cervical lymph nodes. So in checking the cervical lymph nodes, you move towards the back of the patient. Okay, you're supposed to check the cervical lymph node from the back. So you check it sequentially. You check the submental, check the submandibular, then check the preauricular, check the postauricular, then check the occipital, then you check the anterior group of lymph nodes, then check the posterior group of lymph nodes. So you follow it sequentially. So you try to move to the back of the patient. Then, as you're checking, use the tip of your finger to rub on the bony prominences to determine if it's palpable. So check the submental, then check the submandibular, then check the preauricular, just before the ear. Check the postauricular. Mister, can you raise your head up? Then you check the occipital. Check the occipital. Then you check the anterior cervical, which is occurs in 3 groups. Okay, so you check the first group, the middle group, low. Then you check the posterior cervical. Then when you're taking the posterior cervical, then you check the supraclavicular. You tell the patient to shrug. Check the supraclavicular. He said, can you shrug your shoulder like this? Then you check the supraclavicular. Okay. So when you're done checking the cervical group of lymph nodes, you check for skin turgor, hydration status by pinching the skin over the clavicle. So if it recoils, then that means the hydration status is normal. Okay. Then the next thing you are going to check is the axillary group of lymph nodes. Now to check the axillary group of lymph nodes, you tell the patient to hold your hand. Can you hold my hand? Tell the patient to hold your hand. So your right, the patient's right, when you're checking the right, then left, the patient's left when you're checking the left. When you want to check the right, you tell the patient to hold your right. Okay? Patient should hold your right. Then you abduct the shoulder, then flex the elbow. Then you should place the patient's arm on your forearm. Okay? Place the patient's arm on your forearm for you to examine the axillary group of lymph nodes. Now, the axillary group of lymph nodes comes in groups. We have the apical, then we have the central, we have the lateral, then we have the anterior and the posterior. Anterior and posterior. So you try to examine it that way. For the anterior group of lymph nodes, you examine in the anterior axillary fold for the anterior group of lymph nodes. Then you examine the posterior axillary fold for the posterior group of lymph nodes. Then you press the rib cage to examine the central. Then you dig to the apex of the axilla to examine the apical. Then you are free to use the other hand to rub the head of the humerus to try to examine the lateral. Okay? So you examine it in group like that. Then you do the same for the next hand, for the other side. So the patient will hold your left. Can you hold my left? Okay? You do the same. So the anterior, the posterior, the central, the apical. Then you can use this to check for the lateral. Good. So when you're done examining the axillary group of lymph nodes, so you check for the epitrochlear lymph node by rubbing on the medial aspects of the elbow. So you do the same for the other. Okay, rubbing on the medial aspect of the elbow. Okay. Then you go to the palm. So you tell the patient to show you the palm of the hand. Can you keep your palm like this? Okay. So in this, you are trying to check for pallor, palmar pallor. Then you also check for finger clubbing. Then you check for capillary refill. So you tell the patient to show you the palms. Then you must be seen comparing the two. So try to compare the two. Then try to compare it with yours when you're checking for palmar pallor. Okay. Then tell the patient to turn. Turn your fingers like this. Turn your palm like this. Then you must be seen squatting to try to observe. Even if apparently it's normal, you might get normal patients in your OSCE exam, but this is showmanship. You must do it. Show your lecturer you know what you're doing. So you squat. Okay. Try to check for digital clubbing. Okay. So can you do this? Then do this. Okay. All right. Then you check for capillary refill. Okay. By pressing. Okay. You bring your thumb. So you press the digit. You press. Then wait. Press again. Wait. The feeling should be prompt if it's normal. Then the next group of lymph nodes to check are the inguinal lymph nodes. So we have the lateral and the vertical. So the lateral runs below the inguinal ligament, while the vertical group runs along the saphenous vein. So you check, you run your hand along the inguinal region. Okay, check for the lateral and the vertical group. Okay, when you're done, then in coming down, you also check for the popliteal group of lymph nodes. You check popliteal fossa for lymphadenopathy. Okay, raise. Just run your finger in the popliteal region. Okay, then do the same. So when you come to the foot, this is where we check for pedal edema. So you check for pedal edema by depressing against bony prominences and removing your hand and see if it pits. Okay, so we'll start by depressing along the metatarsal. Okay, so try to depress, raise your hand to see if it pits. So if there's nothing there, still check at the medial malleolus. Depress, then remove your hand to see if it pits. If it doesn't pit, you can stop here. But if it pits, you continue till you get to the end so that you'll be able to grade it clinically using what we said in the theory part. So you depress against bony prominences. So you depress against the medial aspect of the tibia. So you press. If it pits, you continue till you get to the end, wherever it stops. So that's how you check for bilateral pedal pitting edema. So if it continues till beyond the knee, then you can check the sacral edema by telling the patient to sit up. Lisa, can you sit up? Okay. So the patient sits up, you depress. Okay. I just like. When I'm done with the examination, that is the examination. The post-examination, you thank your patient. It's very, very necessary. So thank you very much.